Ladies and gentlemen, it is my privilege to introduce Professor Tibor, who is one of the masters of breast pathology living today. He is Associate Professor of Pathology at the University of Uppsala and Head of Pathology at the County Hospital of Falun, Sweden. Professor Toth is the author of the breast pathology textbook titled Practical Breast Pathology, with radiological pathological correlation of breast disease as the main field of interest. He is repeatedly invited lecturer at the European Congress of Radiology, European Congress of Pathology, and other international and national meetings all over the world. His innovating ideas and concepts of the earliest stages of breast cancer are formulated in his C-globe theory that was published in a book titled Breast Cancer, a Lobar Disease. We are privileged to host you in your first visit to Israel. Professor Toth, the stage is all yours.
Ladies and gentlemen, dear colleagues, first of all, I would like to thank all of you for the kind invitation, the organizers. I'm also very thankful for all of you here in the audience, because usually when people hear the word pathology, then half of the audience move out. And you stayed. I am very thankful for it. I would like to show you a kind of concept. It is a concept. It is not pathology itself. It also implies on surgery, on radiology. It is a kind of concept how I suppose to understand breast cancer as a lobar disease. Just for a moment to show you the first image here. Of course, it is my place in the very middle of Sweden. The very famous place you all have heard about the name is Falun. But it has three world famous things. And first of all, in the front of the picture, you see the 900-year-old copper mine. The copper mine which gave the power to the Swedish kings during the centuries, because if you have copper, you can make guns and you can make coins. It is shut down now. However, a byproduct of the mine, the red paint, so typical of the Swedish houses. If you see some Swedish images, then the houses are painted red, and you have a lake and you have a forest. This is Sweden, and then the red paint is coming from this mine. The other thing is up, down, up on the image. It is a winter sport centrum with this jumping tone there, which I have never tried. Although I live 500 meters from this. And then the third one is very important for today. It is the white house there, which is the hospital, and on the 11th floor up here is not the pathology, no, we are in the basement. Is the mammography department, and it was the headquarter of the famous two-county study already mentioned on one of the first slides of Professor Poole. It is the largest mammography trial on the world, and probably the most successful one, or one of the most successful. It influenced also, of course, pathology and the way how we are thinking now about breast diseases and breast carcinoma has its roots in the 70s when this trial was run, and the fruitful collaboration between radiologists and pathologists on the department. I put the main message on the first slide, and it is not this one, but it will be. Breast carcinoma is not a bullet. Breast carcinoma is not a ball in all cases. This is how cyst grows. This is how fibroadenoma grows. But some carcinomas also do this way. But the majority of carcinomas appear like this, here and there in the breast, then continues here and there, and follows a kind of triangle, a kind of lobe. You see the differences in the color, indicating heterogeneity. So this is one type of breast carcinoma, and this is the other type of breast carcinoma. If you have 3 cases, one is such, and 2 is like this. So multifocality, heterogeneity, and so on complicates our life. And it is important, as I told you, not only for the pathologist, but also for the surgeon. Because if you are a surgeon and you is a believer of this concept that every carcinoma looks like a bullet, like this one, then you is satisfied with removing the tumor with no tumor on the ink. If you is a surgeon very well informed about this concept, then you know that you can make a seemingly clear margin between 2 invasive foci without any problem. And therefore, you irradiate all the times when you make a breast-conserving surgery. You need the irradiation. If you are an oncologist and believe that this is the situation, then you may believe that one drug is sufficient and we can cure the patient with one single drug. It is not the situation in this case, because the heterogeneity impacts on your therapy, of course. And then you see it clusters, these foci clusters in a kind of triangle. We believe that this triangle is a kind of lobe in the breast. Breast is a lobar organ. It has about 20 lobes in average, and the lobes are different in size and shape. I will show you this tomorrow also, the very same slides at the beginning. I am just running through them now, inviting to the lecture tomorrow also. Very similar to a lobe, which is a triangular or pyramidal structure with the basis towards the pectoralis muscle and with the tip pointing towards the nipple or being within the nipple. It is of course not a healthy lobe. It is a lobe filled with high-grade DCIS. And this high-grade DCIS is also on the histology, and you see it reminds me about a pyramid, about a triangle, about a lobe. This made me to formulate this concept, the theory of the sick lobe, stating the following, that breast carcinoma is a lobar disease in the meaning that the simultaneously or asynchronously appearing, often multiple in situ and invasive tumor foci originate in a single lobe of one breast. 19 healthy lobes and 1 sick. Okay, originate is the key word here, because during the evolution of the carcinoma, the tumor leaves the area of the lobe. There are some consequences if this theory is true, because the lobes develop already in the embryo. So breast cancer is a lobar disease, according to this theory, originating often in a single sick lobe. The sick lobe is already malconstructed during the embryonic development, and the consequence is the following, that breast cancer is a lifelong disease, beginning in the embryo, which can only be interrupted by elimination or destruction of the entire sick lobe at the early phase of the disease. So breast cancer, we believe that breast cancer is a lifelong disease. I will give you some more details on this theory of biological timing tomorrow. Now I would like only to illustrate with animations. This is a single situation when a terminal ductal lobular unit is filled with cancer cells that makes this lobule larger and deforms deforms the lobule. This is a unifocal disease, of course. Somehow, in many cases, the lobes know when to begin to grow. The process of carcinogenesis is synchronized on distant places within the same lobe. You have healthy structures in between and cancerous structures on distance from each other, developing simultaneously at the same time. This is a multifocal disease. Both the unifocal and the multifocal most often develops in the terminal ductal units, TDLUs. You see here the illustration, one TDLU, the other one, and normal ducts and lobules in between. This is the situation with the cancer when it develops in the terminal units. When it develops in the ducts, because it can develop primarily from the ducts, it can form new ducts also, it deforms and also changes the structure of some of the ducts. Then you have a normal and empty duct here and the duct filled with carcinoma here. We are in the earliest, the in situ phase of the disease, which we can then characterize as a multifocal one, as a segmental or unifocal one, and as a diffuse one. It is a kind of theory up to now, but as we have heard, here may calcifications appear, clustered, small, powderish, and the disease is indolent. Nobody dies. Never say nobody, never say never, but very, very few patients die of this type of the disease. Here the diffuse one is usually associated with high-grade DCIS. And in an invasive phase, half of the patients will die of the disease, irrespective what you do, how you treat. Radiologically, it appears like multiple clusters, as a solitary cluster when it is unifocal, or like this, diffuse. The peripheral pattern, the segmental pattern, and the lobar pattern, we can translate it more understandable, multifocal, unifocal, and diffuse in situ disease. But the show goes on, of course, and it becomes, on many occasions, not always, but on many occasions, it becomes invasive. And then it leaves the normal lobe or the cancerous lobe, not the normal one, the cancerous lobe. We have two different situations now. This is the first one. You have seen, I like it, so I will repeat it for you. You have seen that the invasive cells, the structures, invade in every direction on the same way, and the result will be a spherical or oval mass. In another situation, you will see that on some places the invasion is prevented by desmoplastic reaction of the stroma, and the result will be a stellate mass, a spiculated mass, a star. So one is the circular mass, and this is the spiculated mass. These are the two basic types of invasive carcinoma. You can trace them radiologically, and the spiculated mass, of course, you have the main differential diagnosis is the radial scar or black star or white star. All the radiologists are very familiar with it. And then we have also the round or oval masses, both benign, like this fibroadenoma, or malignant, like this invasive carcinoma. Benign, malignant. Okay. The percentage in our material, all mass lesions operated, about 1/3 belongs to the spherical masses and 2/3 to the stellate masses. But the stellates are usually malignant, while only about half of the round are malignant. These are old data, but still valid. When we speak about the circular masses or oval masses, then we have plenty of differential diagnostic options, from cyst to fibroadenoma to intracystic carcinoma to mucinous cancer to metastasis to ductal carcinoma, and so on and so on. Triple negatives belong here. When we see what type of the tumor, which is round or oval, the medullary or triple negative carcinomas, and the mucinous are, and the high grade. This has the implication, as we have already heard, that these are the dangerous type of the disease. Or of course, the triple negative one. But it is also important how large the tumor is, not only the shape of it, but the tumor size. And you who are familiar with MRA, you know that I was cheating a bit, because the tumors are not spherical in the geometric sense. They are usually irregular in different directions, and the size is not easily accessible. But if we assess it, then we have a category of no invasive tumor, early invasion, which we define as less than 15 millimeter in size of the tumor, and then more advanced cancers. This is the category of invasive carcinomas, and this is the in situ. And this category is the good prognostic category. About half of the cases belong to the good prognostic category in our material. If you look at the screen population, you will see that about 2/3 belongs here. So it is my everyday practice dealing with early good prognosis disease. On our older material, the survival in this category, 10-year survival, is 94%. We did last week a new statistics on our material. On 800 early invasive carcinomas, we had 8 deaths, 1% during a 6-year average follow-up period, which gives you a predicted 10-year survival 97%. And then it is of course interesting because we know publications in the literature stating the following: that there is no difference in survival for those having less than 15 millimeter invasive carcinoma and the average population, provided that this invasive carcinoma is detected with screening. Do you understand what I am telling you now? You have a woman with a small invasive carcinoma, less than 15 millimeter invasive carcinoma. You compare this group with carcinoma to those having no cancer in the population, and there is no statistical difference between them, provided that the cancer is screen detected. I would like to move on and tell you that there are some indications that those having carcinoma live longer than the average patients. Why? Because they are fit, they care about their health, they quit smoking, they are jogging, they have a healthy life, and they are going to mammography screening all the time. They are indications, not publications yet. The beneficial effect of mammography screening and the beneficial effect of having carcinoma. Okay, then we have also heard already that there is a clear relation between the size of the tumor and the type, the genetic type of it, and the surrogate immunohistochemic phenotype of the tumor. Of course, the small carcinomas, like we define it, early breast cancer, it is very rarely basal-like or triple negative, while the advanced are usually triple negative. If you add the shape of the tumor, then you also have this big difference. For example, for triple negativity, 2% here and 19% here, or HER2 positive doubles, and so on. So there is a clear relation between tumor shape and the size of the tumor, and also its molecular phenotype. I promised to wake you up when the important part is coming, and now we are arrived there. Multifocality, or rather lesion distribution within the breast. Is this a multifocal disease? We have this tumor. Is it multifocal when you have only one? Is one more than one? No, it's a unifocal disease. Okay, is this multifocal? Yes, although in the literature you may read that they need a distance between the 4 centimeter distance, 5 centimeter distance. I don't think that the distance is biologically important. This is multifocal. Do you think that this is multifocal? Yes. Do you think that this is multifocal with 4 foci? Yes. Then 5 foci in the same histological section. Or this one, mucinous carcinoma with 6 foci. And this one, ductal carcinoma with I don't know how many foci. This is also a very nice 11 foci within the same section. And this is the absolute world record of multifocality, 118 individual foci within the same breast, a lobular carcinoma. There are 2 types of multifocality. The first one is this one, when you have an in situ carcinoma and the invasive develops on several sites at the same time or approximately at the same time. This is the type 1 multifocality. The other one here is a kind of intramammary metastasis of the disease. So this doesn't develop from the in situ carcinoma, but it is a vascular spread within the breast. And of course, this is more dangerous than this one. Then sometimes you believe that multifocality means that there are some satellites around the tumor, as TNM classification believes in it, but it is not the truth, of course, because there are cases with satellites, and probably they are not so important, but there are plenty of cases when you have approximately same-sized multiple foci, no index tumor, and no satellites. This is the real multifocality. You see a multifocal case just about the same size of the tumor. There is not an index tumor, there are no satellites, it is multifocality. Unifocal disease, 10-year survival, multifocal disease, 10-year survival, and we will speak about this green line very soon. This part of the image is fattily replaced breast tissue. This part of the image is what? Invasive carcinoma. It is not this one which is the invasive carcinoma, but the whole half of the image. This half, the right half of the image, is an invasive carcinoma. We call this type of invasive carcinoma diffuse invasive carcinoma because you don't have a focus to answer. It looks like an architectural distortion on the mammogram, like a cloud. It looks like this under the microscope. The cloudy appearance is illustrated also here. It is not easy to detect. And Professor Kuhl, she talked about MRI and about using MRI in screening. I am now talking diagnostics, not screening, but I am an MRI fan, you need to know. This is not so easy to detect on mammography. Always this architectural distortion can be missed. MRI is better. At histology, we compare it with the spider's web, like the spider web-like carcinoma, as it appeared, like a terminology for it. Do you recognize this type of the tumor in your everyday practice? No. Very, very bad. Very bad, because they are usually very large already when you detect them. And they have been described for more than 100 years ago by Sir Untitled Chapter, May 1906. And it is not the main thing. The main thing is that this is the most dangerous type of breast carcinoma today. So if we make a kind of sum up about the distribution of the lesion, we have a unifocal in situ or a multifocal in situ or a diffuse in situ carcinoma. And we can have a unifocal invasive, multifocal invasive, and diffuse invasive carcinoma. We also know that 80% of breast tumors have both in situ and invasive counterpart within the same breast, which means that the subgross morphology, this distribution of the lesions, is very complex. The complexity will illustrate the following. If we now forget for a moment about the in situ component, then about half of the cases have only one invasive focus. And 33%, they have multiple. In my everyday practice, 1/3 of invasive carcinomas are multifocal. If it is less in your practice, then you need to ask the pathologist why. Then about 5–6% belongs to this very dangerous diffuse invasive carcinoma. Okay, and I make a kind of chart here combining these, and it is very easy because it is only 17 different combinations possible. And you know the reproducibility of this is not so very, but for the practice, this is diffuse because you cannot encircle part of the tumor here and there. And this is focal, and this is multifocal because you can make a circle around the tumor. This is diffuse, and this is multifocal. This one is unifocal also. Diffuse disease, invasive disease, how subtle on the mammogram you see the comparison with the large histological section here, and also we have a histological picture. And this is the line of survival. This is the worst type of breast carcinoma in a screened population, and the survival is of course the worst. 63% survival in 10 years compared to unifocals, which are almost 90. The situation is complicated because also the in situ can be diffuse. Then it appears like this casting type calcifications, long and branching calcifications on the mammogram, or, as we have heard already, not all of them are calcified, but they can manifest as also as an architectural distortion, very similar to the invasive one. And you can also trace them on the MRI like this. Is it a unifocal disease? No, it is a diffuse disease because you cannot encircle part of it. And this is the corresponding large histological section, a 10 centimeter large in situ breast carcinoma, high grade, a dangerous disease. If this type of the disease is associated with an invasion, then we have also a very high mortality rate. Imagine this MRI image. This is normal, of course, and this is not normal. What do you think? Is it a unifocal disease or a diffuse one? Now we have learned that there is a kind of diffuse disease in the breast. If I do like this, an horizontal section histologically here, and put together 4 large histological pieces here, then I see that it was about 10–12 centimeter large in situ carcinoma, high grade, micropapillary, which is a dangerous kind of the disease. It is a big section image or a thin section image of the same thing, micropapillary, high grade, diffuse, very extensive in situ carcinoma. And then we arrive to this, which was already mentioned by Professor Kuhl, that the third dangerous thing is the potato. The potato, which is rapidly growing, circular mass. You see it at histology, mammography, and ultrasound, and also on MRI. Usually they have this rim enhancement often, and in the centrum is necrotic or fibrotic. So the radiologist may recognize it. And they often exhibit also some phenotype, the phenotype of myoepithelium, which we call then basal-like carcinoma. Okay, this table shows me the following. The diffuse invasive carcinomas have a 10-year probability of dying or risk of dying of breast carcinoma over 40%. Invasive carcinoma associated with diffuse in situ, about 30%. Basal-like carcinoma, larger than 15 millimeter, about 22%. Multifocal cases, about 15, 20. And all the rest is green. Small stellate lesions, small circular lesions, less than 15 millimeter, early. Or calcification, small groups here and there. This is probably the overdiagnosed part of the spectrum. So it is the overdiagnosis when you have a cash stone or powdery calcifications only with very, very low probability of dying of the disease. Okay, we change now the show a bit. And I like drawings. I don't know whether you like drawings, but I like. And this is also a kind of illustration for a carcinoma. This is the in situ part of it, the blue, and this is the invasive part of it. Please notice that this is also an invasive, so it is multifocal, and the colors are also different to indicate heterogeneity, intertumoral. Now, what do you think? What is the size of the tumor? How you measure this tumor? Because it is complex, of course. It has two invasive foci, it has an in situ component. We have the difficult task of measuring the tumor. Tumor size is defined as the largest dimension of the largest invasive focus within the breast. So it is this size. What shall we do with the rest? Throw it out? Forget? Because it is disturbing only? Yes, it is the classical approach in pathology. We carefully throw out the rest because we only see macroscopically this one, and we give you the feedback that all carcinomas are unifocal, don't worry. However, if you embed the whole thing in a large histological section, then you will realize that most carcinomas have complex morphology. So this is the size. And this one is the extent of the disease. The extent is also very important. Of course, we know that the size is important, less than 15 or more than 15. And the extent is also important. Also for local recurrence rates, this is the most important surgical parameter. If you wish to remove the whole disease, you need to remove all the invasive foci and all the in situ component. You know that you cannot succeed in all the time, therefore you irradiate. But the difference is very obvious. And we tested that this cutoff of 4 centimeter is just about. You know that about half of breast carcinomas that have this complex morphology have an extent larger than 4 centimeter when you detect. So even if you see a small lesion, it may be an extensive one, a 4 centimeter or more lesion, but the rest you don't see at radiology. Okay, so these are the most important parameters I would like to recommend for you to assess when you are radiologist, pathologist, surgeon, and so on. The distribution, whether the disease is unifocal, multifocal, or diffuse. The extent of the disease, which is the whole area or volume, including all the malignant structures within the breast. And of course the size, which is the largest diameter of the largest tumor focus. And evidence for heterogeneity, because it will be the most important issue in the future. You cannot do it yourself as pathologist. You need colleagues, radiologists, and radiological pathological correlation is essential for making diagnosis today. In breast diseases, there is no such diagnosis that definite pathological diagnosis of carcinoma. The definite diagnosis is radiological pathological correlation, interdisciplinary diagnosis. And when you have this interdisciplinary approach, you need to use the same language. Does the radiologist understand, the surgeon understand, the oncologist understand, and the pathologist also understand something of it. When the radiologist tells you microcalcifications, diffuse, okay, and you answer, is HER2 positive. Is it the same language? Microcalcification, HER2, no. And then comes the surgeon and asks how big to cut. And you say, HER2 positive, nucleolus, microcalcifications. No. He doesn't understand this language. We need the size, the focality, and the extent of the disease, also the position of it. Radiology is repeatable and gives the overview of the whole breast in 3 dimensions. Pathology cannot do it. Pathology is, however, more detailed, more sensitive, and still more specific than radiology. Radiology is better and better. Pathology is the same since the Virchow's. We need to bridge a gap between pathology and radiology, and for this we use the large histological sections. Radiological pathological correlation, if I may use 10 more minutes for this. Do we need a perfect matching? You say, radiologists say 16 millimeter, and the pathology must be 16, then it is correlating. If it is 15, it is no correlation. No, we cannot do it like this way. We need matching categories. And how we create these matching categories? What is the importance of the size, for example? Under 15 millimeter, early, very few deaths, beneficial effect of screening, and over 15, that begins with the death and so on. So if it is matching category, early disease, radiologically, early histologically, everything is okay. But at the same time, we need to look at identical lesions. The location, the size, and the shape of the lesion has to be the same. Here we have a lesion radiologically, here we have it on pathology. It is not a carcinoma, it is a group of cysts. But it's an illustration that the size, the position, distance to the skin, distance to the nipple, and the shape of it is also identical. Discordant findings can be due to compression during mammography, hanging breasts on MRI, distortions during fixations, and many other things. What do you think, which is the most usual one, the most frequent of these, causing discrepancies between histology and radiology? We have published 8 books on radiological pathological correlation, both from mammography and radiological approach and from pathological approach. And have a large section histology since the 80s and all these things, meetings, everything. Still, this one is the most disturbing. We fail in radiological pathological correlation too often. So we need even more training in it. And I hope you are also trained to do this. One biological reason for this difference between radiology and pathology may be the following. Measuring the size, early invasive, less than 15 millimeters or more than 15 millimeters. Ultrasound, MRI, histology, mammography, ultrasound, and so on and so on. Everything is good. 80, 84%, it is achieved. Okay, it's good. It cannot be 100% anyway. So measuring the size with radiological methods and pathological methods, it's okay. However, the extent, and you remember the extent is when you include all the malignant structures, not only one, the largest one. And we make the difference between less than 4 centimeter and more than 4 centimeter. Then those characterized at radiology as non-extensive, 1/3 of them turned out to be extensive at histology. Because histology is a more sensitive method, and because we could detect low-grade in situ carcinomas, we could detect small invasive foci, additional, not seen on the radiology, usually less than 5 millimeters, but of course less than 10. And unfortunately, some rare cases of this devilish invasive lobular carcinoma, which is diffuse. And this is not only the killer today in our material at general. This has also a mimicry, a kind of mimicry, because the diffuse invasive carcinoma, 75% is lobular, and the lobulars are ER positive, luminal A, low grade, low Ki67. All the best you can tell about the phenotype of them. However, they kill 40% of the patients in these cases. Okay, I will finish soon. Microcalcifications can only be detected, of course, by radiology. We see them at histology also, but we usually see something more than the microcalcifications. So microcalcifications are a late event in the development of cancer. So I don't like to read that removing microcalcifications saves the problem, solves the problem, because around the microcalcifications can be non-calcified ACIS in many, many cases. Just to underline what Professor Kuhl already told you, if you add not only poor in situ carcinomas, but also the in situ component of the invasive tumors, then about 1/3 is calcified in our material. The DCIS is calcified in 1/3 of the cases. The low grade, less often, this high grade in half of the cases. Okay, we also published recently on very small tumors, unifocal as they characterized by radiology, so radiologically unifocal tumors. But they turned out to be multifocal or having an in situ component in about 40% of the cases. So this is a discrepancy because pathology is still a more sensitive method for it. Do you see this slice and the mammography of this? You also see the circle the radiologist made here. And this is the tumor for radiologically. Unfortunately, it is a diffuse invasive lobular carcinoma. And this is the area of the invasive lobular carcinoma. Do you see anything here which is infiltrated by the cells of the tumor? No, it has a mimicry. It can fool us very, very easily. Simple questions. Breast pathology is primitively simple. The radiology is much more complex, but breast pathology is simple. You need only to have some very, very simple diagnostic questions. And the first one is, how many suspicious lesions are there in the breast? One, then it is unifocal. More than one, then it is multifocal. I cannot count, then it is diffuse. How large volume they occupy in the breast? Less than 4 centimeters, good. Breast conserving surgery can be done. More than 4, probably need a mastectomy. How large is the largest invasive lesion? Which means the size of the tumor. And are the lesions similar to each other or different? Then it is heterogeneity. Which means the following for me, that making a diagnosis of breast carcinoma today doesn't mean anything. A core biopsy stating that it is a carcinoma has no value. The value is when you know how many lesions are there in the breast. Are they extensively occupying the breast volume or not? Are they similar to each other? Is the largest focus large or small? Then you have prognosis. Then you help the surgeon go to mastectomy, breast conserving, okay. And you help the oncologist, because if it is a large size tumor, then possibly a neoadjuvant therapy is needed. But a simple diagnosis, breast carcinoma, don't give you these parameters. We need, in practical approach, preoperatively, to help solving the question about the type of surgical intervention in the axilla and in the breast. And I will illustrate it for you. Is this a unifocal disease? Yes. Multifocal disease? Diffuse disease. Preoperatively, it is the radiology running the show. We only have a core biopsy for example, from here, and the core biopsy from here, and we only can say, yes, it is carcinoma, but look at radiology and you will know whether it is unifocal, multifocal, or extensive or not. Extent, okay. We jump over this. Post-operatively, we have a problem because we pathologists now are coming to run the show, not the radiology. Our method is better, more sensitive. If we use large histological section, we need to check the correctness of the preoperative findings, check the correctness of the treatment applied, for example, resection, and provide prognostic and predictive parameters as we do that. And the basic rule in radiological pathological correlation for the pathologist is the following. All the lesions detected with radiology must have a histologically verified correlate. Yes, it was a cyst, yes, it was a fibroadenoma, but this was a cancer. As a method of higher resolution and higher sensitivity, histology may detect radiologically occult lesions. So this is a must, this is a may. Okay, some images only how we do it in practice. We use this plate, the surgeon puts the specimen on this plate, then the plate is radiographed. We use this radiograph when we cut up the specimen. It is a guide for us, and the radiogram and the large histological section has to match each other very well. The orientation is preserved. In this case, we have an invasive carcinoma here, another invasive focus, so we see that it is a multifocal tumor. We have in situ foci here. We know the size of the lesion, we know the extent of the disease, and also the margins in one plane. So this is a very useful tool, large section histopathology. And then we know this resection margins, unifocal disease, tumor on the ink, but multifocality is the issue because you may have seemingly clear margins and invasive and in situ foci may be left. So clear margins doesn't mean that all the lesions are excised. Pulse breast margins, radiological report is not complete. Do you, as a pathologist, have a complete radiological report when you make a histology of a tumor? Yes, it should be. It should be, because it is not a pathological diagnosis, it is interdisciplinary on radiological pathological correlation. And post-operatively, we have the large section confirming that this was unifocal, this was multifocal, this was diffuse. And this was multifocal but of limited extent, and it was extensively multifocal disease. I use the large section, of course, for all these parameters. It doesn't mean that I don't have small pieces for the phenotype of the tumor and for the lymph nodes. Interdisciplinary diagnosis based on correlation of multimodality radiology imaging findings and findings in large format histopathology slides is the best practice, gold standard today in diagnosing breast carcinoma. Thank you very much for your attention.
Questions? Please.
I will repeat your question. Yes.
75%
Correct.
but what's the other 20%?
Mm.
And if they are like basic uphill, like dark or positive, what is the so-called good damage?
Yes, yes, it's a very important question. If I may be not so modest, then I can say so like this. For 10 years ago, I published a paper in the Werkhoff's archive entitled Diffuse Invasive Lobular Carcinoma. and last year, diffuse invasive ductal carcinoma. So there is a 25% of these diseases which is ductal and not lobular. If it is lobular, the survival is about 20%. No, sorry, the mortality is about 20%. If it is ductal, the mortality is about 50%. And these ductals are unfortunately not so nice in phenotype as you expect. So there are even more dangerous diffuse diseases. Usually luminal B. Yes. Any other questions?
Actually, I have a question concerning large sections. How many pathology laboratories in the world use this? Because it is pretty rare to see this system of
Yes.
pathology histology.
This is the most usual question I get about the technique. The next is what does it cost, and how long time it takes. Okay, so we studied the two last questions, and okay, if you take one or two pieces from a visible tumor, then it is cheaper and more quick diagnosis. When if you image the same area with your small blocks, then the large one, then the large is cheaper, less expensive, and the large is less time consuming. To illustrate it, when I ask my technicians, do you wish to cut 3 large blocks or 150 small? They like the large, absolutely, because 150 is a very laborious 2-day job for them. Okay. How many laboratories? There are very few laboratories, unfortunately, but there are a few of them in Turin, for example, also in Bologna. We have 3 centers in the US using it, 1 center in Canada, and so on. So this is sporadical. But there are publications on large section histology and colorectal cancer, large section and prostate, large section and penile cancer, and so on and so on. I have to make one more point here, because how large is the large? This I am showing you is a 10 by 8 centimeter large section. There is a smaller brother of it, a 7 by 4 centimeter, and we call it megacassettes. And megacassettes are very usual in pathology, breast pathology laboratories too, and prostate and those. So I can tell you, for example, that megacassettes are used in all breast centers in Sweden, but the large sections are only in Falun, unfortunately.
So actually we have to change all our equipment if we want to use these methods, in order to say if it is multifocal, diffuse, or
Yes.
unifocal.
We need to. It is a concept. It is a concept. It is not a method. It is not a technique. So we need to change our approach to the subject, and then the rest is easier.
Thank you very much, Professor Todd, for this exciting lecture.